Inborn errors in metabolism, amino acidemias, organic acidurias, urea cycle, glycogen, and sugar metabolism disorders. Clinical presentation of metabolic disease. It's usually a non-specific problem of lethargy, decreased feeding, and vomiting. These symptoms can progress to seizure and coma. Similar symptoms can be seen in a number of etiologies, including congenital heart defects and sepsis. So the newborn crash is really defined as a term infant with a well interval. The reason they initially look healthy is because even though they don't have the enzyme, the placenta does. The mother has the enzyme, so she can filter things, but once the cord is cut, the baby is now on its own, and whatever this is that the enzyme's not working, the metabolites start accumulating. It usually starts with non-specific poor feeding, vomiting, lethargy that can progress to seizure and coma. Occasionally, there's an abnormal odor to the urine. So differential diagnosis of a newborn crash, the number one thing, the number two thing, the number 10 thing that anyone would think when you have a healthy baby that then rapidly deteriorates is that there's an infection, that there's sepsis. But there are other things as well, including adrenal insufficiency, congenital heart disease, asphyxia, amino acid abnormalities, urea cycle abnormalities, organic acidurias, and mitochondrial disorders. This is by no means a perfect diagram, but this is one of the best that I could find when trying to look at how we look at inborn errors in metabolism. So you have lethargy, coma, seizures. Are you acidotic? If you're acidotic, where is that acid coming from? Is it coming from organic acids, as in the case of propionic methylmalonic, or sometimes maple syrup urine disease, like an amino acid disorder, or is it coming from lactic acid? In the case of primary lactic acidosis, mitochondrial disorders such as pyruvate carboxylase and dehydrogenase, or secondary lactic acidosis, which could be a glycogen storage disease, another amino acid disorder, tyrosinemia, or galactosemia, or even coarctation of the aorta. The lactic acid can elevate because of the difficulty of going through the aorta. If there's not acidosis, what is the ammonia? And elevated ammonia can be seen with a number of urea cycle disorders, OTC, asparaginase, and citrullinemia, arginase. And finally, if everything's normal, it could be something like PKU or non-metabolic. So metabolic acidosis is caused by decreased blood pH caused by the accumulation of hydrogen. There's usually decreased bicarb, decreased PCO2 because of compensatory hyperventilation. The question to ask is the metabolic acidosis the result of abnormal loss of bicarb in the case of diarrhea or accumulation of acid? And so we use the Henderson-Hasselbalch equation to measure the anion gap. Plasma sodium minus chloride plus HCO3, and normally it is between 10 and 15. When the anion gap is elevated, that's a sign of an inborn error metabolism as well as some other things. So metabolic disorders result from the accumulation of organic anions. Clinically, there's usually a persistent and mild acidosis with intermittent episodes of acute decompensation. So here we have another diagram. We have metabolic acidosis. When we have a normal anion gap, that's usually because of loss of bicarb in the case of diarrhea or RTA, renal tubular acidosis. When it's expanded, that's because of accumulation of fixed acids, organic acidopathies, lactic acidosis, or ketoacidosis. In an older child or an adult, the number one reason to have metabolic acidosis with a fixed acid is ketoacidosis, or DKA. However, in a newborn, neonatal diabetes makes inborn errors in metabolism actually look common, so we're usually looking at either an organic acidopathy or one of the causes of lactic acidosis, which include some of the organic acidemias, urea, like tyrosinemia, coarctation of the aorta, the galactosemia. So organic acidurias, there are many different disorders that result in the group of organic acidurias, and you do not need to be able to differentiate one from the other. Clinical features include decompensation the first 2 weeks of life. They can occur later with a partial enzyme block, and for instance, Glutaric Acidemia presents later than most cases. Acidosis, elevation of anion gap, elevation of lactic acid, and hypoglycemia are all signs of organic acidurias. So again, you don't need to differentiate. Methylmalonic, isovaleric, propionic, and glutaric acidemias are organic acidurias. So clinical features include ketoacidosis, elevation of glycine and amino acids, hypoglycemia, bone marrow suppression, and mild hyperammonemia, not to the range of the urea cycles, which we're going to talk about in a second, but more like 200 to 600. Glutaric acidemia, as I said, is one of the organic acidemias that present a little bit later than most. Usually present around 1 with an incurrent viral illness. Prior to the first episode, the baby may have an enlarged head, but otherwise relatively normal development. There's actually decreased brain tissue and increased fluid, so it's actually microcephalic macrocephaly. Often children, like I said, have relatively normal development until the first episode, and the top picture is a little girl at 1, and the bottom is after she's had an acute decompensation episode. Other features of glutaric include profuse sweating and unexplained fevers and irritability. The diagnosis of glutaric acidemia is made by identifying elevated glutaric acid on urine organic acids. The MRI with acute episodes can show lesions to the basal ganglia as well as multiple subdural hematomas. These subdural hematomas result from tearing of the vessels because of the small head and the extra fluid in between. However, subdural hematomas can be mistaken for child abuse. So if you had a child come in with signs of abuse, bruises, subdural fractures to the skull, bleeding behind the eye, known as retinal hemorrhages, and you see subdural hematomas, that's probably abuse. Whereas if you have a child that presents with more of a septic type picture and you possibly see multiple small subdurals with no real external trauma to explain it, as well as maybe hits, lesions to the basal ganglia, that's more likely to be a concern for a metabolic disease such as glutaric acidemia or aciduria. Amino acids are the building block of proteins. There are essential amino acids and the remainder are made from each other. Various enzymatic defects result in the inability to convert one amino acid to the other. Maple syrup urine disease presents between the first couple weeks of life. The ammonia could be normal to mildly elevated, lactic acid is usually normal, glucose is normal, and there can be a maple syrup odor to the urine or the earwax. The incidence is about 1 in 100,000 to 1 in 300,000, but it's 1 in 200 in the Mennonite population. Maple syrup urine disease is inherited in autosomal recessive fashion, which means you have to have 2 copies of the gene not functioning correctly. The Mennonites in Pennsylvania are very inbred populations, so rare recessive disorders are seen in this population. Maple syrup urine disease is caused by a non-functional enzyme, BCKD, which catalyzes decarboxylation of the alpha-keto acids leucine, isoleucine, and valine to their respective branched chain CoAs. Elevation of isoleucine results in the sweet smell to the urine, and elevation of leucine is transported to the brain, and in the brain it's converted to glutamate and glutamine. And this glutamate and glutamine cause the lethargy and damage to the neurons. Phenylketonuria is another recessively inherited amino acid abnormality. Phenylalanine is normally converted to tyrosine. We have our amino acid pools, and the way that we break down phenylalanine is just break it down to tyrosine, then further broken down. This is done by this enzyme phenylalanine hydroxylase, and when this enzyme is not functioning correctly, the phenylalanine is then shunted to phenylpyruvate, which is then turned into a number of acids, and these are toxic to the brain. If untreated, children with PKU can lose 50 IQ points in the first year of life. So here's a video on PKU.
Phenylketonuria, or simply PKU, is an autosomal recessive disease in which there's a problem in one of the enzymes involved in the metabolism of phenylalanine. Now, before we look at the details of this particular disease, let's take a look at the actual metabolism of phenylalanine as it takes place in normal individuals. So as we ingest food that is rich in protein, the protein is broken down into individual amino acids. And one of these amino acids is phenylalanine. Now, about 25% of the phenylalanine is actually used to build new proteins inside our cells. But the remaining 75% phenylalanine is used in the liver to actually generate another amino acid known as tyrosine. Now, tyrosine is also used to generate new protein because we need 20 amino acids to generate protein. But the remaining unused tyrosine inside the liver is metabolized via these steps into acetoacetate and fumarate. Now, acetoacetate is transformed into ketone bodies, and fumarate is transformed into glucose. And the cells of our body can use the ketone bodies and glucose for energy. So that's the normal process of metabolism of phenylalanine as it takes place inside our body. Now, what's the problem in patients with PKU? Well, by definition, phenylketonuria basically means high levels of phenylketone, also known as phenylpyruvate, in our urine. Now, where do we get phenylketone from? Well, when we have accumulation of phenylalanine inside our body, that phenylalanine is transformed into phenylketone, also called phenylpyruvate. And so we see that the problem in these patients is elevated levels of phenylalanine. And the only way that we elevate levels of this molecule is if this reaction does not take place at a high enough rate. And that's exactly what the problem is in patients with PKU. The problem is within this step. So we have phenylalanine that is transformed to tyrosine by this enzyme. So phenylalanine hydroxylase is a mixed function oxygenase that uses a cofactor known as tetrahydrobiopterin. Now, this is not a vitamin. It's a cofactor that is built inside our cells, inside our body. So if there's a problem within this enzyme itself, or there's a problem in actually building this cofactor, this reaction will not take place. And so the person will develop phenylketonuria. Now, the most common cause of phenylketonuria is a defect in this enzyme. And this is an autosomal recessive disease. What that means is the patient, to have PKU, has to get a defective gene from the male parent and a defective gene from the female parent to actually develop symptoms of phenylketonuria. So carriers of this disease essentially grow up to be normal. Now, if we have high levels of phenylalanine, what will that cause? Well, high levels of phenylalanine will essentially affect the myelination of the neurons inside our body, inside our brain. And so high levels of phenylalanine will essentially cause defects in brain development. In fact, people with PKU have low IQs. Now, this is a very dangerous condition if not treated. In fact, about half the patients with PKU who are not treated die before the age of 20. And about 75% of the patients that are not treated die before the age of 30. However, if we treat this condition early on and continue the treatment throughout the lifetime of the individual, that individual will essentially grow to be normal. Now, how do we treat this problem? Well, essentially, the patient that has PKU before birth, they have no problems. Why? Well, because the mother has the enzyme to actually catalyze this step. And so any phenylalanine within the mother will be transformed into tyrosine. Now, following birth, There's also no problem. Why? Because that patient has not yet ingested protein rich in phenylalanine. But as soon as that patient is born and then is fed, they essentially obtain the protein, break down the protein into phenylalanine, and then they cannot transform the phenylalanine into tyrosine. So now this phenylalanine will begin to essentially accumulate within the blood and tissue of that patient. And so this is precisely how we can actually diagnose a patient with PKU. Because patients with PKU after birth and following the first feeding cycle will have levels of phenylalanine that are 20 times higher than those of normal patients that don't have PKU. So by drawing blood and finding high levels of phenylalanine in that infant, we essentially can diagnose that infant with PKU. Now, how do we treat this patient with PKU? Well, essentially, we have to limit protein intake, and we limit specifically phenylalanine. So we give just enough phenylalanine for that patient to be able to build new protein, but we have to limit that phenylalanine because the patient can transform that phenylalanine to tyrosine. So to summarize, Phenylketonuria is essentially a condition in which we find very high levels of phenylketones inside our urine. Why? Well, the problem lies within this step. Usually there's a defect in this enzyme, phenylalanine hydroxylase, so we can't transform phenylalanine into tyrosine. And so we're going to build up phenylalanine inside that individual. The phenylalanine will be transformed into phenylpyruvate, also known as phenylketone, and that will begin to appear within the urine of that patient.
Okay, so the next thing we're going to talk about is homocystinuria. Homocystinuria is caused by the inability to convert the amino acid homocysteine to cysteine because of the deficiency of the enzyme cystathionine synthetase. As a result, we have elevated homocysteine that results in a prothrombic state, which also can increase the risk that the patient will have blood clots. Homocystinuria, unlike most metabolic disorders, patients can have dysmorphic features. They can look like something known as Marfan syndrome. They actually think Abraham Lincoln had Marfan syndrome. So patients with Marfan syndrome are actually tall, with long fingers, hypermobile joints, and patients with homocystinuria look very much like that. They can also, unlike Marfan syndrome, patients with homocystinuria have cognitive delays. Patients with Marfan syndrome actually have an upgoing lens dislocation, whereas homocystinuria, it's downwards. So patients with homocystinuria, this metabolic disease, the way sometimes people with mnemonics think about it is the chemicals that, they have an accumulation of homocysteine that pulls the lens down. Urine smells and metabolic disease. Maple syrup urine disease can have a maple syrup smell, isovaleric, sweaty feet, and tyrosinemia, rotten cabbage. So, the next thing I want to talk about is urea cycle disorders. The purpose of the urea cycle is to dispose of nitrogenous waste and to make the amino acid arginine. When the cycle is not working correctly, the ammonia can be very elevated. The incidence of urea cycles is about 1 in 30,000, with X-linked ornithine transcarbamylase being the most common. So here we have the urea cycle. The first step is we have our ammonia that we're trying to get rid of, and we attach it to a CO2 and make carbonyl phosphate. Ornithine is combined with carbonyl phosphate to go to citrulline. When this enzyme doesn't work, that causes ornithine transcarbamylase, which is the first step of the urea cycle. The second step is citrulline adds an aspartate to go to original succinate. And when this does not work correctly, this results in elevation of citrulline, which is seen on amino acids, or citrullinemia. Original succinate lyase is going from original succinate to arginine. So this is how we create arginine. And the last step is taking off a water-soluble, so the ammonia is released in a water-soluble method, which is known as urea, that goes to the kidneys and then is excreted. And we go back to ornithine. Symptoms of urea cycle: because of the accumulation of ammonia, the patients are actually alkalotic. So they look septic, but instead of being acidotic, they're alkalotic. The ammonia, as I said, can reach into the thousands. So let's talk about a case. We have a 3-day-old, and some of the important things when you're looking at metabolic disease is how old is the child. So a 3-day-old presenting to the primary MD after discharge from the nursery. He was born full term without any complications to a 32-year-old first baby, and all the serologies were negative, and the group B strep of the mother was unknown. And the mother states that he's having difficulty breastfeeding, and she wonders if she should change the bottle. And she notices he throws up a lot, and his urine has a sweet smell. In life, or definitely when you're taking step 1, if they tell you about the smell of the urine, take that very seriously and underline it. The baby has lost 7% of his birth weight, and the physical exam is unremarkable. 4 days later, the baby presents to the ER unresponsive, hypertonic, and he begins to seize. So that's a bad thing. So the blood pH is 7.34 with the HCO3 of 15. So we're probably going down here. The ammonia is 180, mildly elevated, but not to the point that we're going to think about a urea cycle. The lactic acid is 1.4, so on the upper limit of normal, and mild hypoglycemia. So we're acidotic, but it's not coming from lactic acid. It's probably coming from over here. Unlike organic acidemias, the urine organic acids will help determine, likely the organic acids will help us determine this disorder. The second one is a baby born by repeat C-section. The first day of life, the baby's nursing well. At 36 hours of life, he now appears hypotonic, lethargic, and is hypothermic. The blood gas is 7.49, with normal being between 7.38 and 7.42, with an HCO3 of 26. Septic workup, including CBC and LP, are normal. But in this case, the ammonia is 1500. So here we have a baby who's not necessarily acidotic, but his ammonia is very, very high. So this is probably one of the urea cycles. Again, the most common being OTC, especially if it's a boy, but if it's a girl, you'd probably be thinking more citrullinemia. And you'd need to do enzyme analysis to determine which one. So if we have a 4-day-old male that presents with lethargy, decreased oral intake, and blood gas with a 7.49 and ammonia 1200, the most likely diagnosis is galactosemia, aortic stenosis, maple syrup urine disease, ornithine transcarbamylase, or PKU, and the correct answer would be OTC. And again, when you're looking at exam questions, especially in step 1, it will probably only be one urea cycle, so as long as you know which they are. The next thing I want to discuss briefly is sugar metabolism. So we talked about breaking down of amino acids and organic acids, and now we're going to talk about the breakdown of sugar. Galactosemia is caused by the inability to break down galactose, or to convert really galactose to glucose. Lactose consists of glucose plus galactose. So glucose is really easy to use, but the galactose then has to be converted back to glucose. And there are 3 enzymes, but the one most common abnormality is GALT, or glucose 1P uridyl transferase. When the galactose cannot be converted to glucose, it's converted to a toxin known as glycotrol. And this is toxic to the liver. It results in jaundice, as well as accumulation in other tissues, such as the lens of the eye. In the urine, it's excreted as unmetabolized sugars or reducing substances. Galactosemia is clinical features include jaundice, an enlarged liver, vomiting, feeding intolerance, and E. coli sepsis. The reason for the E. coli sepsis is that galactose is very much liked by E. coli, and the E. coli amplifies. They also get cataracts because of the accumulation of the glycotrol into the eyes. Untreated, babies can rapidly progress to hepatic toxicity or death from sepsis. So again, they can very rapidly develop E. coli sepsis because of the galactotrol in the body. Treatment includes a lactose-free diet. If you can't break down lactose, then you shouldn't give it. Soy formulas such as Similac and Enfamil. Unfortunately, breast milk has lactose, so this is tested for on the newborn screen. Glycogen storage, another way we accumulate, store energy is in glycogen. So it's a bunch of glucoses put together. And the problem is if we can't break those back down. So a group of inherited disorders caused by the inability to break down or synthesize glycogen. The hallmark of this disease is accumulation of glycogen in tissues such as the liver and the muscle. It occurs in as a group about 1 in 20,000 to 1 in 25,000. Type 1 is von Gurke's, which is the inability to convert glucose 6-phosphate back to glucose. Again, we need glucose and we need it to get it from other places. Type 3 is a debranching. Type 4 is another debranching. And type 6 is liver phosphorylase. But we're primarily going to talk about type 1 glucose 6-phosphatase deficiency or von Gurke's disease. Usually this presents between 3 and 4 months of age with a very enlarged liver, but this baby actually has failure to thrive. Very thin arms and legs with this kind of cherubic face and very enlarged abdomen. They have hypoglycemia, which can result in seizures. So we have hypoglycemia, lactic acidosis, hyperuricemia, and hyperlipidemia. The treatment is to prevent hypoglycemia with continuous feeds with like cornstarch, something very easy to access energy from, restricting galactose and fructose from the diet. So again, here we have the lethargic baby, they're acidotic, and they have lactic acidosis. It's actually a secondary lactic acidosis in the case of galactosemia, and glycogen storage, and galactosemia. Type 3 debranching. So this is, again, here's our large glycogen. The von Gurke's is kind of the last step of breaking down glycogen, but here's one of the earlier steps we have these long chains and we need to break down the chains and then we need to break down the glycogen. Symptoms of debranching defects include a large liver, hypoglycemia, short stature, skeletal myopathies, and the most important muscle in our body, cardiomyopathy. Muscle disorders include Pompe disease and McArdle's. I will discuss Pompe disease when we talk about lysosomal storage diseases, so I want to talk briefly about McArdle's, and then there's phosphofructokinase. McArdle's is a glycogen storage disease caused by the absence of the muscle phosphorylase, the PYGM gene. It's inherited and recessive, and the absence of this enzyme reduces ATP by glyconeogenesis. Usually symptoms begin in the early 20s. There's muscle cramps during, like, for instance, weight training. They can have a burgundy-colored urine. It's not actually blood, but it looks like it. And we see elevation of creatine kinase or CPK, which really goes up after exercising. And again, they can have a lot of muscle cramps and muscle breakdown. Really severe muscle breakdown is known as rhabdomyolysis. The diagnosis can be seen by muscle biopsy by identifying glycogen within the muscle, or DNA testing for the PYGM gene is 100% of patients with this will be found with mutations. The treatment is avoiding strenuous exercise, IV fluids with glucose during times when they have the rhabdomyolysis or breaking down the muscle. Phosphofructokinase, this is the lack of the enzyme that breaks down fructose 6-phosphate to fructose 1,6, and it's similar to McArdle's, but sometimes it occurs earlier. The difference is it can occur earlier in childhood. They can have hemolysis, elevated uric acid, and this exercise intolerance can be worse after a carbohydrate meal. So this ends this particular lecture series.